My great pleasure to hand over the mic to our chair for today. Well, we've had a few words already about the IFHE from Fabio, and I've introduced the speakers. So let's get started with the discussion. Thank you.
Sure, thank you. And I should say, my little slide here says I'm the CEO of Mazzetti in the US, which is true, but much more important in some ways for this conversation, I'm also the president of the International Federation of Healthcare Engineers. And we're very grateful to IHF for this partnership and the ability to work with you on this really exciting panel. So I have spent 30 some odd years now in the design industry, really focused on healthcare facilities. And I remember at one point I was doing a research project on the issue of electrical safety in operating theaters. And I spent about a week watching an orthopedic surgeon as he did his magic and literally changed lives. And I remember thinking at the time, I would love to be somebody who could do what he does. I would love to be able to have the power to make change, positive change in people's lives for the good. And then I remembered that part of the reason I went into electrical engineering was that I couldn't handle chemistry. And so I decided I better just stick with what I knew. But what I think has been really, truly rewarding about that is the ability of the design profession to provide a stage on which the people who are able to practice healing are able to operate. And I've been able to watch through the years a number of great architects, of great designers who have really excelled at providing that stage and really focusing on how to provide improved operation, improved support for healing through their art. And we'll get to hear from three of them today, which is really exciting. Um, in the world of architecture, a famous architect a number of years ago pointed out that form follows function, which means it is really the job of the designer to create the form that enables the function, um, in this case, of practicing healing arts. And so we have three superb speakers. Have you already talked about Q&A, Alona? And okay, so people know Q&A. So I'm going to, at this point, turn the mic over to them because they're far more exciting than me. And put your questions in the chat and we will get started. So thank you, Amy.
Pleasure. Thank you, Walt. Thank you, Iona. I'm just going to share my presentation quickly. Well, welcome everybody. I am usually based in Cape Town in South Africa, but currently sitting in Durban on a site visit. So I'm happy to present from my hotel room. In my role as an architectural design manager, I take facility needs and turn them into practical, cost-effective solutions, always guided by the 7 flows of healthcare. I'm passionate about designing environments that make a real difference to both patients and providers. Hi, I'm Amy Kraus. I'm a professional architectural technologist with nearly 26 years of experience. I've spent the last 20 years focused specifically on healthcare architecture. Over the years, I've worked on projects across Africa in both public and private sectors. And I currently serve on the executive committee for the South African Federation of Healthcare Engineering. My work centers on creating efficient, compliant, and well-designed healthcare spaces, optimizing layouts, improving flows, and supporting better clinical outcomes. I consider adopting the Bauhaus design principles, form to follow a function. It means the shape of a building or object should primarily relate to its intended function or purpose. But one can also look at it in the context of an existing building. How functions may have changed over time, and can we adjust those functions to work with the current form so that it does not always mean an expensive building project? Just a thought. I have a deep passion for working in existing hospitals. The challenge of implementing change in existing structures excites me like bubbles of champagne. However, change can be daunting for many, and we must ask ourselves, Does the form truly need to change? Can we approach it from a different angle? Listening to the users is crucial. If the system has worked effectively for years, why disrupt it? Or can we refine it to make it more efficient? What is the actual problem? And is there actually one? How can a flow or a schedule change and not a total rebuild? In this presentation, I will give the high-level overview of these 7 flows of healthcare, highlighting their complexities and their challenges in aligning them with stringent building regulations and Department of Health requirements, with the end users' expectations and opinions, with the principles of form follows function. Often these elements of the 7 flows of healthcare face pushback from staff due to the lack of understanding or regulatory constraints, making clear communication vital. I emphasize the importance of presenting a comprehensive visual outline early in the process to ensure all stakeholders have a common vision and understanding before a project commences. This ensures safety, workflow efficiency, and overall functionality. Over my years of experience, I've learned the key to success in healthcare design is objectivity. Approach each project without personal opinions of myself, doctors, staff, and management, but that may not reflect the end user's need or the future reality of the facility. But by adhering to principles, I aim to create healthcare environments that are not only compliant and functional, but truly supportive of healthcare professionals and patients alike. Let's dive in. The flow of patients, probably the most crucial flow through any healthcare facility. From the arrival to the movement between units during your stay at a hospital to the discharge. When one is limited by vertical or horizontal flow, one has to think out of the box. How can we use what we have got and how can we work with it or adjust it to make it flow better? Regulations with widths of passages, sizes of rooms can be restrictive, but you can be creative with the flow of patients. Rooms are ideally laid out to ensure clinical safety, but this is not always physically possible in the older facilities. One has to be creative, but it is crucial at all times to get the feedback and understanding from the people that are going to be functioning in this area. Flow of family and relationships. The statement "family heals faster" generally means the supportive family relationships can positively impact recovery from physical or emotional injuries or illness. As a designer, one must always remember the families. A room typically is divided into clinical, patient, and public. This can ensure the attendants of the clinical providers have access to the patient first with ease and not having to move the visitor out of the way. Flow of providers. This flow is so crucial to the efficiency of a facility. If the movement of medical staff, doctors, nurses, and other healthcare professionals are hampered, this can cause major problems. We have guidelines to ensure that central nurse stations are positioned crucially, and also in some designs, one has to allow for satellite stations for better patient visibility. We ensure that access to utility rooms are centralized to assist with the rapid response for the patient, as they are the key person. Change in an existing facility where providers have worked in a facility in a certain way for 3 or more years is sometimes more challenging than the regulations themselves. This is what inspires me as a designer, how to make that change understandable to somebody who does not understand plans like we do, and how do you make the ease and the adjustment of it flow simply. Flow of medication. Often the flow and access to pharmaceuticals and other necessary medicines within the facility can be quite far from the units that they supply. The placement of the pharmacy is crucial in the design. It should ideally be on the route of the exit of the patient out of the facility to collect medication for take home on discharge. But one can also look at a pharmacy location for the units that it supplies. How long will it take? What is the staff impact? What is the time turnaround? How can we make it work better? Each facility is different. one has to just understand how the user is intended to be used. Flow of supplies. This refers to the movement of general supplies, such as linen, cleaning materials, and other consumables. It is a flow map I map out with every single facility. It is often a flow that is an afterthought. One always forgets about the back of house. With older structures, this is where one really has to be creative. This building that you're seeing here is over 100 years old, and we are currently under construction. The amount of storage required for a facility is not determined only by the size of the facility, but the number of beds, the type of procedures, but also its accessibility to services and supplies. Often outlying areas need larger storage to ensure that money is not wasted on the numerous trips required for suppliers to supply a facility. The location of support services, like a cleaner's storeroom, central cleaner's storeroom, a laundry, or a kitchen, can impact drastically in the turnaround of patients in a unit, not an impact that one would think of often. The flow of information, a crucial flow in the movement of patient data, medical records, and other important information. This is an area that is easily forgotten and understood. From the moment that a patient is booked for a procedure or admitted and assessed at an emergency center, the flow starts. The flow that is left currently to human form, be it by hand or computer. The storage of patient information is captured electronically, printed on 1 million stickers, for everything to do with that patient. And then the patient is followed by a file full of stickers through the process in the facility. This patient file is confidential. The files must be stored from anything from 8 to 21 years according to regulation. Confirm this flow always with your facilities. It is crucial. It can also be forgotten that in our ever-changing world of electronic health record systems, how do we implement that, even if it is a future thought? Flow of equipment. One often overlooks the wide variety of elements involved in a healthcare facility operations. When I embark on a project, I thoroughly investigate this flow with every component in the facility. Room data sheets are crucial in our world of design. Room data sheets are structured documents that outline specific requirements for each room and space in a hospital, in a building project. This ensures the flow of equipment can get into place with minimal interference, be it moving a C-arm from an equipment store into a theater, or an element out of the kitchen up into the wards. This ensures we need to look at the services for this equipment to ensure that all health and safety elements are in place. This also is impacted on by building regulations. In conclusion, now we have a form that is following the function with the 7 flows of healthcare in mind. Much easier said than done. This is where communication to the operational team is crucial to have their understanding and buy-in for a project to work properly and to run efficiently in the long run. The importance of a user-centered design in healthcare involves encouraging to rethink existing workflows for better outcomes. I often challenge hospital managers, unit managers, any person in a facility. How can we do it differently? What is there? Is there something that you thought of that you don't want to voice? Maybe we can design around it. In my final thoughts, the potential for architecture to enhance patient care and staff efficiency through these flows is crucial, simple, but also extremely complex. But it can be done. Thank you.
Hey, I'm seeing a lot of hearts and clapping coming up. So I think, Amy, people valued your thinking. So thank you for that. Fabio, I think you're up next.
Thank you a lot, and it's a very important opportunity to discuss it. Let me show. Okay. First of all, it's very important to say thanks to Ilona Johnston of IHF, International Hospital Federation, and my friend Walt Vernon, now the president of International Healthcare in Engineering in Federation. It's very important for us, your presence, and our friends Amy and Alexander Venier. Well, bridging the gap is the word perfect for this moment. And specifically with this opportunity to bring a discussion with this functional solidarity and flexibility in architecture and engineering for health as important discussions and these strategies and case studies for sharing and use. Then this discussion about bridging the gap, the moment, the opportunity, and this discussion specific about functional solidarity and flexibility, and in some cases, studies for shared use and this discussion. And always I remember a recommendation of WHO in a Safe Hospital and Safe Patients, a collective responsibility report from 2020, when it says that vulnerability of a hospital is more than a medical issue. And that's very important for us. In 2020, in pandemic times and a very hard moment, the IHF, International Hospital Federation, in a congress in Geneva, discussing adapting buildings and equipment and present the human perspective from architecture engineer for solidarity and functional hospital. And in this moment, we discuss some meanings of solidarity and these discussions about some combination of terms, multi-words and expressions often used with solidarity, act of solidarity, team cohesion, solidarity alliances, feeling of solidarity, and other ones. And in that case, I remember some use in the pandemic times of ephemeral solutions in Rio de Janeiro, boat, a hospital boat in the river in Amazonas to offer the healthcare service in Amazonas, and another ephemeral and definitive facilities that we've been bring from São Paulo. Well, these discussions offer also an opportunity to discuss expansibility, flexibility, contiguity, connectivity, and conformity in a solidarity functional position and moment for discussing it for bring the concept of solidarity in the use of the hospitals on internal spaces should show in many cases that is not necessary to build anything new, just divide and sharing functions permanently or temporarily. Nothing must blunt the plasticity and care for human comfort as an important remembering. Here, I would like to present some examples from United Kingdom and Brazil of situations, cases, and projects that consider the axis of solidarity through flexibility of use as a relevant strategy to be applied in the planning and management of hospital buildings and other health facilities. The first one is the Alderhay Children's Hospital in Liverpool. It's a very interesting project that wins a lot of awards. And this discussion is a project from the BDP design and the start construction in 2012. And the inauguration, it was in 2015. Land area, 285,000 square meters. The built area, 60 square meters, and more 32,000 meters of parking. And with 270 bedrooms. It's a very interesting concept and implementation in a Springfield Park. That's the main building, and all this area is growing and expanding positively and offering for the community this area for the living today. Then these expanding activities to connect with the surround community from the main building. The main building is here, and the park is growing, embracing this area. Is an opportunity to offer in a solidary way with the community this space. And inside the hostel, that is the main area, the central circulation space at the Alder Hostel is an important example of solidarity functional used to adapt the assistance activities during the COVID-19 pandemic and other situations requiring assistance, healthcare assistance. It's a very interesting. We had been in 2019 with the IFHE group visiting, and it's really wonderful. And from Brazil, we have a reference of architect João Filgueiras Lima, known Lele, as a very important architect from us in Latin America and Brazil specifically. And we have a project in Sara, Lago Norte Hostel. It's very interesting. This project is from March in 1996. The construction started in December 97. Inauguration December 2003, with 80,000 square meters and a beauty area from 25 square meters, 1,000 square meters. We have also the same numbers of bedrooms, 270, 270, and it's a very interesting concept, and it's built in a very interesting area in the Brasilia, the capital of Brazil. Here is the Lake North, Lago Norte, Lake North, and there's a great area that's offered to community, opportunity to be in and use this space. The patients use this area to the activities around this. Inside, we have these gardens and use of natural light and with a process of contribution for the recovery of the patients. And here on the outside of one of these experiences, we have the colorful wall and bench for people to wait outside, are an important expression of solidarity with those who do not need to enter the hospital environment, the family, the parents, and all them. And this one is another experience now in Rio de Janeiro, Sara, Rio de Janeiro is another experience. The project from November 1999, construction is start in April 2002, inauguration December 28, and land area 78,000 square meters, and built area 52,000 square meters. We have a little more bedrooms, 330, in a very interesting place here in Rio de Janeiro. Rede Sara is 12 hostels all over the country of Brazil in the different regions with this concept of open areas and connecting the opportunity to be in natural landscape and natural area with these lakes and landscapes. And inside we have the use of color as a reference of comfort and a way to offer to the patients the opportunity to be in and be out as a place of comfort to all, for the parents, for the relative, for the patients, and for all users of this space. Thank you, Walt. Okay, that's enough. Thank you.
All right. Thank you so much, Fabio. And I will mention that in 3 years, Fabio will become the president of the International Federation of Healthcare Engineering, and at a meeting in Brazil. So we invite you all to come and see some of those architectural masterpieces Fabio just shared with us. Now we're really thrilled to be able to turn things over to Alexandre.
So thank you. And good afternoon or good morning, everybody, wherever you are. Welcome, everybody. My name is Alexandre Vanière. I'm one of the two project architects of this building that you see, the new Children's Hospital of the Lausanne University Hospital, which is one of the 6 university hospitals that we have in Switzerland. What I'm going to present, and then you will see that it's going to somehow join what was presented by Amy, the 7 flows, or by Fabio as the fundamental aspects. I will present that on the angle of our responsibility as public contracting authority or owner's perspective. That's important because we're not the designers. We're not the proper architects of the building. We're the pilots of the whole operation, and that, of course, includes a few responsibilities. So basically, a few figures. The hospital we're talking about is like grossly half the size that the Liverpool one that was presented earlier by Fabio. So it's 36,000 square meters, built for 100, a bit more than 100 beds. I'll go quite quickly through that. We can come back if there's any questions about that. So basically, that's the location. One of the main things was the density of the surroundings. As you can see on the left, before-after picture, we had to kind of install a huge building, more than 200 meters long, into a hospital complex, which was already quite dense. You can see that on the Google Earth image that was taken during the building site on the left, and another view from the north, including a garden, a big garden on the roof itself of the building, in order to kind of give back the piece of land that was occupied by the new hospital. A few pictures inside, so you can see afterwards in the explanations what we're talking about. Grossly, some hospitalization rooms, of course, pictures taken before the patients, and then the consultation spaces on the ground and first floor. The surgical blocks as well, to see the technicity of all that, and the facts that we did manage to give some natural light within these spaces that are quite confined and sterile. Another point was the links within the city, overground and underground, all the connections, which means that this building is not only a new infrastructure by itself, but is also a connecting point between all the hospital complex, since it is built in its middle. So that was a new project. So of course, the expected outcomes were the replacement of the former one, an increase of surface, the reunion of all the activities on one only site, the enhancing of patients and family roles, and the anticipation of further needs, which means preparing the hospital to be ready for the next, say, 40 to 50 years. And that includes a few responsibilities, which kind of joins what was presented by my colleagues earlier. We considered them as 5 main points, but of course we can add some more, which is to make something that is functional, the best health and social infrastructure, that of course complies with all the relevant laws and regulations, that considers at first the patients, so the children and their families, as well as the caregivers, that of course, since it's public money, does not exceed the allowed budget, and environmental, since of course we have responsibility in terms of environment and carbon footprint. I don't go exactly through all these things, but that means grossly you understood that it's basically from the first needs assessment and definition, the conduct of studies, including the money supervision, and that all the project changes that was highlighted before, as well as the project reception, the necessary certifications, and then the follow-up that we're doing now after commissioning. So the hospital is functioning since a bit less than a year now. So I have now two slides that are a bit complicated and technical, but I think are interesting because it kind of illustrates the process that we as project owner had to go through to make sure that all our needs are met. So basically, we start with an initial design from the architects that you can see left on the upper side. And then we prepare some scenarios. This is the déchocage in French, so the resuscitation room, which is located immediately after the ambulance and helicopter access. So it's like the life-saving room. Of course, a room that you cannot miss. So basically, we did elaborate some scenarios. Then we did some real dimension testing into the building site with a final report that ended up to a final layout. That means that we had to go through all this process together with specific teams of caregivers, medicals, rescuers, caregivers, nurses, logisticians, cleaners, providers, suppliers, and so on. And of course, our technical staff, because we're also responsible for the maintenance of our equipment. Second case study, the room, which is maybe not as crucial as the resuscitation room, but kind of this the center, say, of the hospital. So we did several checks, first within the building site on the left, then after in the real room that was like chambre témoin, that was done before the others, and same, we did test in critical situation, in ordinary situation, we did test the positions, the dimensions, the materials, the technical equipment, to make sure that once it's built, it meets exactly all the needs of the users. Another point was this site supervision in general. We're working in an occupied site. You have on the left, the yellow building is the maternity, and the picture is taken from the main hospital building, which has all the main surgical rooms. So this tube that you can see on the left was a tunnel that was kind of excavated when we did build, and which remained in function during all the building sites. And that means that we had to cope with an existing hospital working day by day, minute by minute, and a building site, which is, as you can imagine, of different impact and size. Another thing was that on the right one, the hospital is built above a metro station. Once again, it's strictly, of course, forbidden to work during the working hours of the subway, because we have, as you can see, we have concrete beams that weight more than 50 tons each. So we had to organize the works at night, which means also to collaborate with the police forces, with the subway management system, and all the city administration. So basically, this was grossly our role as pilots of the project from the internal point of view. Another thing, just to illustrate the level of complexity, as you all probably know, this is the surgical rooms, and we had to make sure that, of course, we had some specialized engineer designing all this technical stuff, but then we had to make sure with our internal teams that it fits with the needs and with the needs of maintenance, because once again, we're in charge of this specific maintenance in order to make them work 24/7. This leads us to some before-after image. As you can see, so that was the intensive care room on the right, on the left, and desk on the right. And this is what we start with and what we end with in terms of facilities. All that, of course, was constantly supervised by us architects, but also hand in hand with all a bunch of caregivers, logisticians, cleaners, suppliers, and so on, to make sure that it actually meets every step, every need at every moment. And then so finally, a sort of resume of this responsibility that, once again, I believe kind of reaches the 7 ways that was explained by Amy, or the fundamental aspects that were presented by Fabio, as we are in charge of providing the best possible item infrastructure that comply with all the laws and regulations, keep the patient at the center, save the public funds, obviously, minimize the carbon footprint, and contribute as architecture to the city's development. And with this, I will end my presentation, and thank you very much for your attention.
Thank you, Alexandre. That was a wonderful presentation. Walt, can I hand over to you to deal with the questions?
Yes, thanks to all the panelists. They were wonderful presentations. I'm always impressed by the creativity of architects and the way that they're able to combine beauty with function in ways that are meaningful over time. And so I really appreciate the presentations. I actually am going to ask one of my own, and then we'll go to the ones that have been sent in, and then I have a much longer list of questions to ask about. But all of you talked about the role of complying with regulation. And I am a little curious about that. I remember, again, as a young engineer, being held back by what I felt like were old-fashioned rules that had been written a long time ago and were out of date, and really struggling to do something new and better. And I remember arguing with a code enforcement authority at one point, and he said, Walt, if you want to do something different, you go change the codes. And so I actually got onto some of the code writing committees where I've been changing the rules ever since. And I am curious, we do have a responsibility clearly to be compliant, but at the same time, practice evolves. And I wonder if you could comment on the responsibility that we have, not only as design professionals, but also as the people who own buildings that need to perform a function. What is our responsibility and opportunity for improving the regulations that so many of us are required to follow? And I don't know, maybe I should call on you. And it's probably different in different countries. And Alexandra, maybe I'll start with you on that question.
Okay.
Thanks, Walt. Well, I think it's a brilliant question. It's exactly the center of our jobs. So basically, as you said, we have to comply with and then possibly to change them. And basically, what I was thinking about is that we have this kind of whole group of regulations that go from urban regulations, since we're limited in height of the building, in dimensions. Then we have to comply with technical regulations, since we have to provide some safety in electricity systems or this kind of stuff. Then we have to comply with market regulations. We are linked to the WTO rules that makes us, as a public commander, say, obliged to respect some financial rules. And then we have also all the certification systems that, in order to be able to cure the people in certified surgery rooms, then we had to prove that they are at the level. And of course, we have all the bunch of the environmental rules. We have a limit in the carbon footprint, in the consumption of goods, in the insulation of the building, and so on. So basically, I think that our role is constantly to be a sort of referee and to balance in between these different regulations, including those who are possibly in conflict one with each other. And we're sort of referees into that. And then by the time, I also believe that our experience, when it comes back to a sort of lessons learned, then can be possibly the opportunity to change the rules. Since the Grand Conseil, the political institution that pays the project, is also the one, it's the legislative of the region, it's also the one who provides the laws, who makes the laws. So it's very interesting because it's to them that we feedback on our lessons learned and experience, and it's their responsibility as legislators to possibly adapt the law to the latest experiences. That's my point.
Really helpful. Thank you. I'm going to move on to the other questions so we have time for them. Amy, if you don't mind, I'm going to ask you to answer a different question.
That's 100%.
I was going to ask you, one of the questions that has been asked is about how to involve clinical users in the design process. And here I might expand the question because as a designer, I think you do want to hear from the clinical users, but at the same time, the clinical users only know what they know. They don't know maybe other examples and other ways. And so you have to balance that, but also you have to balance that against the regulations and against budget often. And I'm just curious, and our audience here is a lot of people who lead healthcare organizations. How should they support a design process that enables you to create something that'll be helpful for them?
So I think it's probably the most crucial stage in any format. What I found with over the years is management is key, but then again, management doesn't understand how a scrub nurse works in a theatre complex. They might not understand how the person that takes the laundry up to the wards and packs it away and the process of that, how does that work? So when going into existing facilities or even designing new facilities, one's got to call on all the information, all the key role players, any information from any facilities that you've worked in. And also it's what you've learned past experiences and how you can improve going forward. Because I always believe that you might have thought that you finished a fantastic project, and I myself have thought yeah, that's a great project. It's all 100%. And I go back 6 years later and I go, oh, what the hell? I need to change it. But one of my biggest things with theatre complexes, which is a passion project of mine, is understanding every single human being that works in a theatre complex, down from the person that's literally moving the food to the doctor's rooms or replacing the scrubs or actually a doctor, very opinionated people. But anaesthetists have been like my champions of a theatre complex because they sit and watch. And they look at a lot, and it's to understand also from the engineering side, how does it work? Can you get to it? I think that was one of the questions there. How do we impact our architectural world and our design and our requirements and our needs and everything, but then ensure that you tick the biggest box of IPC, clinical flow, regulations, and all of those. There are so many balls up in the air when you are even just looking at one operating room of a 7x7 meters. There's so many different moving parts, but you've got to listen. You've got to understand. Obviously, money is the biggest thing, but you've got to understand also in the long term, and that's room function for the next 20, 30 years. Can it evolve with technology? What can we dream of in the future that we can even just put a conduit in a wall that possibly they could pull in a robot or something like that? One's got to try and think out of the box, but think in the box. But it's about listening. Most of my design processes are actually sitting in the ward or the theatre complex and just watching. I think people watching is probably the best pastime of an architect ever, because the movement of people through a building will tell you so much more than what a clinical person will tell you. They'll tell you a different form, but just watching is huge. It makes a huge, huge, huge difference. So yeah, so it's a variety of things.
Thank you. Fabio, I'm going to turn to you, and I'm going to ask a couple of related questions, if I could. And these are focused in some ways on integration of engineering with architecture and clinical outcomes. One of our questioners has asked, this is all very nice to produce beautiful buildings and even buildings that work for clinical purposes, but at the end of the day, if it isn't maintainable, it doesn't work for the long run. And so I'd like for you to reflect on two questions. Number one, this question about how do we include considerations of operations and maintenance of the building, the asset. This will be the most expensive asset that an organization has, and it needs to be able to last and to provide function for a long time. And then related, there was a question about engineering. And while architecture, in a way, is the skin and the organizing principle of a building, what makes it breathe and think in some ways are the engineering systems. And so how do you, as an architect, integrate the engineering into the design and then ensure that the organism will endure and be operable and maintainable?
Perfect. Thank you, Walt. Okay, that's the great challenge that we live every day. Every time we begin to have the work of planning a hostel, we fight with a lot of problems. The connection between the distinct demands, clinical demands, the problems of the area, the technical solutions and the standards and the regulations, distinct, wide, so wide, and at the same time, we are in the road that we are always offering new ideas, new concepts, new ways of developing contributions for all, for the maintenance, for operators, for the direction of the hospital and clinical always. And well, I think that is the great challenge that we live, is just to connect these distinct demands, this distinct and is not easy. It's not easy. It's not a easy way to conduct these discussions. But is the a problem that we have to face in each time? Well, I have to first is to know how much better the regulations and the process and at all. And the second one is have a methodology of to work. It's important to show each step, to show each phase of the process, in the planning, in the construction, and after in the management of the hospital and another structures of healthcare. Well, it's a great challenge, but the opportunity to hear, discussing, learning with another experience like Alexander and Amy bring this experience and this important moment of the IHF and IFHE bringing these discussions for all over the world with distant visions, with distant problems, with distant demands, and that we have to face each time we are in the process of planning of constructing a hostel or a small structures of facilities of healthcare. That's always in this trouble, but it's a very, very fascinating process.
All right.
May I just add, I'm sorry.
Sorry.
May I just add something, because I think that the question was very, very crucial, and Fabio's answer was very interesting. I would like just to add something, is that you spoke about the fact that architecture is kind of the skin for the medical technical stuff. The other point is that we noticed is that we do not work in the same time frame, and that actually the time of construction is far bigger, far longer than the one of medicine. For instance, we had scanners that we decided to buy on the last 3 months because our radiographic teams wanted to have the last model. So that means that in terms of architecture and engineering, we had to anticipate what could possibly come afterwards. And I think this is also a very important thing, is this sort of anticipation of things you don't know exactly what they will be made of.
Well, that's really great. And I have to tell you, I wish I could have this conversation all day because I have a million more questions, but I know we're getting to the end. And so we're all going to get the hook here in a minute. I will say this. For those of you who put questions in the chat and we didn't get to them, I think we could provide written responses and send them out to all the attendees so that we'll try to honor the questions. Um, let me ask, and I'm going to actually change our order here a little bit, but I want to ask a question about sustainability and equity and our responsibility as design professionals in this area, because we often are paid by people with a lot of resources to design buildings for people with a lot of resources. And much of the world really does not have much access to healthcare. One of the things that I have run into over and over again is a dilemma that says, well, for if we're going to design a clinic for low resourced areas, we need to follow all of the same design standards as if it were a hospital built for Rio de Janeiro or Geneva, Switzerland. And the dilemma always is, if we have to design it to those standards, we can't afford to build anything. So is something designed to a lower set of standards better than nothing? Or are we really engaging in design malpractice to design something less for one group than we do for another? I think that's a real moral dilemma. And the other moral dilemma, I think, in our time is, for us as designers, the WHO has called climate change the defining health issue of our time, and said that we have to cut greenhouse gas emissions 50% by 2030, which means anything that we're designing today needs to have zero emissions, and we need to cut the emissions of existing buildings by 50% in a very short time. And I'm curious how you think the design and leadership of healthcare organizations ought to be responding to these challenges. And I'm going to go in a different order. I'm going to let Fabio go first this time, and then we'll go Amy and Alexander. You only have about 3 minutes each. So let's see what you can do.
Okay, thank you. Always for us architects, we remember the basic concepts reference from the solution for inside the hostel, for better conditions for the hostel, is outside, is in the sun, in the wind, in the area, in the conditions outside, that we can promote the best conditions of development for the future. And to obtain the best results, we have to consider the primary conditions of creating the project. Then I think we have to consider to get to be in top of the best results in development for the future. We have to consider the natural conditions, and each country, each region, it has different demands and different materials to be applied in the solutions. Then the solution, fantastic solution of Alexander in Lausanne, or another one in Brazil or Liverpool in United Kingdom, is not the same to the Africa, for Asia, for Latin America at all. We have different regions here in Latin America. The Amazonia area is completely distinct of Rio de Janeiro, São Paulo, and other regions. We have to consider the main materials is outside, the sun, the wind, the natural conditions, to get the best results for development of the quality of hostel for the future.
Amy?
Yeah, so I think pretty much like South America, South Africa probably has the same sort of aspect in a variety of economic situations. I think when using material and the word sustainability, it's a very wide world in our architecture. We can design for sustainability for the 2000s, but what happens in 2050? What happens in 2080? How has the world evolved? can that hospital still maintain itself even in 10 years' time if you put this fancier materials in, because it might not be financially viable for that hospital to sustain it. So one's got to take financial impact on the facility and how big it is and the area and the economic growth that it's in. Understand, can the maintenance be held up from it? Because maintenance is such a wide word. I mean, some of the facilities that I visited can all be of the same group, but cannot be maintained in the same way because financially they cannot afford it. And they have to take shortcuts, or they have to make adjustments or adapt to the environment. So it's all great to push the green and the sustainability, and I'm all for it. But at what cost to the client? What cost to the government if you're designing for the government? What cost to the people to maintain it, and always have to justify as to why they require to upgrade or to maintain it to keep with their green ticks. You know, how about building a building that can last a lifetime without adding to it or changing it, with it not being a big impact on the world? You don't always have to look at that. I mean, yeah, it's just a way that one has to evolve. But it's open-minded, but then what's the budget? We always have to think of budget. We'd love to not have a pocket. It would be great, wouldn't it? But especially in South Africa, I mean, money is always the first thing that's on the top of everybody's mind. What is the return on investment going to be? And a lot of times, a thing like double glazing is like, you've got to be joking, which is the simplest. Yeah.
I will note before we go to Alexandra, the National Academy of Medicine in the US is actually getting close to publishing a white paper on how to finance decarbonization programs. And so keep an eye out for that. Alexandra, do you have an answer to this question?
Well, shortly, because my predecessor just said everything almost. But just maybe one point is that I kind of go back to your just what you said about the paper that was issued. Is that basically, I think this speaks in favor of having also and to maintain a strong public sector, because it's also this one that can sort of engage through some laws and regulations and everything we were talking about before, that can ensure that no one is left aside. And that's the proper mission of the health system, is to take care of everyone and everywhere and the environment. And I think this is a strong plaidoyer, strong advocacy to maintain a public health sector, including in construction.
Thank you. That's a great answer. All right. Well, I guess I did jump the gun a little bit. We still have a few minutes. So I'm gonna ask one last question of each of the panelists. And this one, you'll only have about 1 or 2 minutes, but if you could describe what you think the biggest innovation that's coming to the design of health facilities is in the next 5 years, that in particular, not only designers, but also owners of hospitals and healthcare buildings need to be looking towards, what would that be? And Fabio, I give you, well, I see you went first last time. Let's give Alexandra the first shot at this.
Oh, that's not easy. Okay. How could I answer that? I think that more and more, but it's not a proper innovation. But I'm not thinking in terms of technical of medical stuff. I think, but that's a personal impression, that more and more we have to talk. We have to be transversal, and we have to be totally transparent. So that means that I think the main novelty, the main new thing that will arrive is this obligation of networking and transparency. We had to work according to more and more people interested to talk with patients, probably far more than what we did 40 years ago, to consider everyone. We did work the respect. I don't know, for instance, we were constantly reminded, and that was good, of the existence of the Charte Européenne des Droits de l'Enfant, European Chart of Hospitalized Children's Rights. And that's basically one of our red routes that we had to follow. So I think one of the main thing is regarding everything, environment, healthcare, funding, political, and so on, is this obligation of constant networking and transparency on what we do, for whom we do it, with which money, and in which consideration for the environment. I think that's the main change.
Great. Thanks so much. Amy, any last
Communication.
thought?
We know how to communicate, but do we communicate clearly in everybody's language? Because a mechanical engineer thinks like they think, an architect thinks like we think, but a hospital manager has a completely different vision. And then that communication from management to doctors to clinical back to us. I mean, communication is the oldest form of anything in the world, but yet we do not communicate clearly. And one must never take it as, I actually had a discussion today with a doctor. I said, you can read the plan of my body because you understand where every organ lies, but you might not be able to read the plan of a hospital. So let's assist each other with finding the correct communication to go forward and design the best building and design what you require. So it's not an innovation, but it's about understanding how to communicate.
Terrific. Fabio?
Okay. Well, I think we have to think again about the solidarity, expanding the use of space and environments, and thinking about solutions that reduce costs is a problem of healthcare all over the world. Well, the maximum for the minimum. That's the way. We can have an explosion of construction of new hospitals without a plan to each population of each ward, considering the importance of reducing costs and the concept of sustainable materials and solutions. Well, I think we have to consider it in our planning, in our solutions, in our discussions for new solutions. Okay, solidarity is very important to think each time we have in planning a new healthcare space.
Thank you all. All right, it is my privilege to be able to thank our three amazing panelists from different corners of the world, Amy, Fabio, Alexandra. And I also want to thank Ilona for helping to organize and produce this presentation, and the International Hospital Federation for the partnership that we are building between IHF and IFHE. We will try to send written responses to all of the questions to all of the attendees. We will also be posting a recording of the entire webinar on both the IFHE website and the IHF website. And at least speaking from the IFHE, somebody noted that they couldn't believe this was a free webinar. And one of the things that we're doing now is offering monthly ongoing webinars. And so if you came to our website, ifhe.info, you can learn more about those. And we'd invite everybody to join us. And so I want to thank everybody and wish you all the best. Take care.